medical degree, and then went to the University of Minnesota for his internship. His many specialties. Tonight he's speaking to us all on laser ablation surgery.
Hi, a pleasure to be here, and excited to talk to you about some new technology that we're sort of on the cutting edge of at KU that is being used all across the world at the moment. There have been, I think, about 300 cases done now in this country. We're still learning about it. There's a little ways to go, but I thought I would introduce the technology to you and tell you about what is called laser interstitial thermal therapy, both for primary brain tumors, gliomas, glioblastomas, astrocytomas, and for secondary tumors, meaning metastatic tumors, tumors that have spread from somewhere else. We are branching out to use the laser therapy for other types of tumors and other lesions, in fact, and I'll talk about that a little bit. My partners kid me all the time about my what they call laser therapy, but it is actually from a company called Monteris Medical, and we use something called the NeuroBlate is the kind of the trade name, and it does use robotics. And I've been asked for years by my patients, am I going to use laser to resect their tumor? And finally I can say, yes, we are using laser to take out the tumor. Lasers have been around for a long time in medical applications, and there are various types of lasers. You can see, I'm not sure, is the mouse working up there? Yeah. So there's the non-contact laser, which you would simply, shine a laser at the tissue. I have a laser here on my phone. The lasers that you use, the little pen lasers, these are all different types of lasers or non-contact lasers. So, this is a laser here that is non-contact. You're not touching the tissue with it, you're firing the laser at something. Then there's the contact laser, the lasers that you have to actually touch to the tissue to transfer the heat energy or the light energy. And then there's interstitial laser, and that's what we're using here. This is the one, the application you can see here. And we use a wavelength in this range. The red wavelength between 620 and 1200 nanometers provides low absorption and deep penetration, which is optimal for this type of treatment. What we do is we take an optical fiber that's carrying the laser energy at the tip of the probe that heats the tissue, basically heats the tissue up. We've had ways of doing this in the past with something called a thermistor or electrical probes that you put deep into the brain or in other tissues, and you really just heat the structures up. The beauty of what we have now is you can see the laser working in time. I mean, you can see how much you're killing with the laser, you know when to stop, when not to injure adjacent tissue, and you can see if it's not heating in a certain direction as well. Whereas before, we would strictly put a probe into the brain, into a tumor or into another part of the brain, turn on the thermometer, and we knew how hot the tip of the probe got, but we didn't know what it was doing to the brain. So this is really a kind of a groundbreaking technology that we have available. We use various types of technology to do this, and it's all done in the MRI scanner with you asleep. So, for instance, if you see if I can get this to work here. Oh boy, that's not. Need to try and get the movie to play here. So the probe is inserted. You see this little tripod device that we put here on the surface of the skin, and then the probe can be turned robotically. Remotely. We're in another room when this is happening, sitting in front of a console like this, turning the laser to one side or the other, or using the robot to pull it in or out. Here's another example. You see the laser firing from the side. We have two different types of probes that we use. One is a diffuse tip probe. The other is side firing. The diffuse tip has only been available to us here the last few cases we've done. But you can see if your probe is eccentrically placed, you can turn it so that it fires more in one direction than the other, and then turn it and fire here. And what we're trying to do is get these little temperature lines, which show sort of the kill of the brain tumor, to extend out to cover the entire tumor that you see here. So the beauty of this is we're not actually opening the skull, opening the skin, going in there with our instruments and resecting this. We're putting a laser in, and the laser is doing it. And then we'll see, so we rotate it here to kill this portion, and this is actually what's happening. If you were to look at the tumor, this is what's happening inside the head, and we're watching it in the MRI scan in real time. About every 8 seconds, a new MRI scan is obtained that shows us the increase in temperature. It's really a proprietary software program that is able to detect changes in temperature, and we know if we heat the brain or tumor or any other tissue up to a certain temperature, that it will kill everything within that temperature line. So using the sapphire capsule, which is very transparent to the wavelengths we're talking about, the laser is actually automatically cooled while it heats. So it heats up and is cooled down in a cycle similar to what you see here. And the reason for that is we don't want to burn the end of the laser and heat everything up so it becomes a char. We want it to be able to not char the end of the tip. And so here you see the laser exit direction, and what happens is it cools with CO2 passed down through the tip of the laser, cools it, and then heats it back up again. Alrighty, and this shows you pretty much what we were showing before. What we see is a thermal map that develops, sometimes very quickly, other times in not so quick a manner, depending upon what types of tumor we're ablating or we're killing. We don't really know. We're using this right now in various technologies. We don't know what it's best for, what tumors will ablate quickly, what tumors will come back once they're ablated. So all of this is relatively new. We know that it is minimally invasive, and it is effective when you see the heat map expand as it does here to cover the entire tumor, and I'll show you some of those studies. We can drag the laser down or drag it back simply by touching here with almost a joystick or dragging it with the mouse, and the robotics will drive the laser down and pull it back. There are 3 different thermal levels that we follow. What we call the yellow line, the blue line, and the white line. The yellow line is the equivalent of 43 degrees for 2 minutes, the blue line for 10 minutes, and the white line for 60 minutes, meaning pretty much everything in that white line is liquefied. Everything in the blue line, protein is denatured, and in the yellow line, we believe we have cell death and cell membrane disruption. So these were some of the first animal studies. This is very, very well scientifically grounded and very well studied. This was a live animal study in porcine model, I believe. You see the brain here. How amazing how tiny the brain is in such a big head. And here's the lesion. You see the lesion here. This was Dr. Price did this, a veterinarian, and here you can see that with the diffuse tip probe, that is the probe that kind of extends the laser out in all directions, you have a radial penetration with the laser of up to 1.5 centimeters. With the side firing probe, you can get sometimes a little bit farther than that, up to 2 centimeters beyond the probe. I don't need to show you that slide. This talks about procedure time. So this is comparing what we would call our standard operation, a craniotomy, to a small laser ablation, and skin-to-skin times in one study of 7 hours, operating plus MRI scan of 6 hours, resection time 4 hours, and decreasing the time almost in half using the NeuroBlade at this one particular center. So again, the robotic probe driver is placed on top of this tripod-like device. Right now we actually have a bolt that we're using actually more frequently, and you see the laser is driven by a surgeon at a console that is remote. So we're looking out the window into the MRI scanner, sitting in front of a console, and driving the laser in and out of the tumor and turning it from side to side. You can control the margins very nicely by turning on or off the laser. Again, here you see an example of what it would look like. And we're watching now 3 different planes is what this is. So if you would imagine a slice taken here, a slice taken here, and a slice taken a little farther back. That's what we're looking at here. Orthogonally, in other words, at 90 degrees to the trajectory of the probe. And you see the heat is expanding here, but it's also expanding deep to this slice and above this slice. And again, we're going to want this heat to approximate this 43-degree line for at least 2 minutes to surround the entire tumor. Of the day of surgery, patients are admitted the day of surgery. So they go to sleep, anesthesia puts them to sleep. We immobilize the head and have them on a frame that is easy to move in and out of the MRI scanner. The anesthesia helps us with numbing up the scalp as well, and then we establish a trajectory and place this little, either the tripod device on the head, or we have another way of stereotactically using a computer guidance to plan our trajectory. And then we screw a tiny little bolt in there, and then everything is dismantled and the patient is taken down with the bolt in the head, covered up sterilely, down to the MRI scanner. There are some centers that have intraoperative MRI, and we're currently in the process of building one of these in our new building. Won't be ready for a few years, but the intraoperative MRI is nice because then you don't have to move. The patient doesn't have to move and have the trajectory, the possibility of bumping of the little bolt. So it's a little nicer that we don't have to move, but in our case we take great precautions. We now have this bolt that is absolutely screwed into the skull, so it really doesn't move. And then in the MRI scan, after we obtain the MRI scans, we begin the ablation, watch the thermal dosing delivery every 8 seconds with a new MRI, and then remove the device. The device is a 3 millimeter laser probe, 3 to 4 millimeters, and then once we remove it, we put a stitch or 1 or 2 staples in the skin, and that's really it. This sort of shows you how we used to do things a few months ago. Now we're doing it with a bolt that screws into the skull, but this was a little access device that we have. We get our trajectory planned so that we can target the lesion in the optimal trajectory for the laser probe. You can either do more than one laser probe, you can do more than one trajectory. We had a case today where we did that, one from each side of the head going down to ablate a larger lesion. And then we place the probe in, lock it, and then turn on the ablation. Here a patient's going down to MRI scan, and I think I just explained that to you. The procedure is done. We are standing or sitting out here in front of this workstation while you are in here, patient with the tumor to be ablated, while we're watching the tumor be ablated. And then person is moved into the scanner after we're standing out here. Here is the robotic device, and now imagine all of this has to be MR compatible. So this is all made out of plastic. And this device here is controlled by me from another room remotely. All right. This is simply another movie that talks about or shows you how we plan our trajectories. Once you're down in there, we will line up the lesion, which you can see is deep within the brain here. This is several centimeters. The only way of getting at this previously is to take off a piece of skull and make a nice track all the way down to this tumor. We have to go through some normal brain. And then here you see the trajectory being planned. Let's see here. And as you lower this plane here, you see the plane at a right angle to it, showing how the probe will pass right through the tumor. And then you start obtaining the MRI scans, which show us the temperature of the brain around the probe. And then the probe is lowered into the tumor. This talks about creating a second trajectory, which we can do in cases of larger lesions so that we can be sure and ablate the tumor. So we will, in that case, as in one we did today, we placed actually 2 bolts, one on each side of the head to get into the tumor. And then it looks something like this, where we see the Green temperature means, green means go. We start ablating when we'll see the go signal over here. We'll step on the laser and begin to fire. And as we do, you see the temperature, the color change here from green to red, and instantly you'll begin to see a blue. You see this little blue line here starting to grow over time, and we'll want that blue line to grow and ablate the entire lesion. And then you see the probe here is now based towards the bottom of the tumor. What will then happen is once we see this blue line encircle the entire tumor at these 3 slices, which are these slices right here, 1, 2, 3, then we'll drag the tip of the laser back and fire it in the upper part of the tumor. So the whole procedure sometimes takes 4 or 5 hours. The actual laser firing is maybe a couple of hours. And in some people, the tumor is more concentrated, and so the temperature does not grow as fast. In other people, you will have, for instance, a large vein right here, or the ventricle. These are ventricles of the brain filled with fluid. And then what happens is it acts as a heat sink. So you've got a vein there that's got a lot of blood rushing through there, and you're trying to heat the tumor up, but the temperature is going into heating the blood instead of heating the tumor. And so we will try as we might, we can't get the laser to reach the far confines of this tumor here, so we'll end up with 90% of it dead and 10% still left. This is not at all too dissimilar than what we do surgically. When we go in surgically, we open it up, we have a microscope, we look at the edges, we try and inspect and make sure everything's out of there, but there may be some cells left behind that we are unable to get that cause the tumor to grow back in the future. And then after surgery, we're able to look at exactly how much of the tumor we have ablated or killed. 90%, 100%, 95%, et cetera, and make some assessment of how successful we think the lesion was, or the treatment was. Here's another lesion very deep in the brain coming in from behind. And then when we closing is very simple. We simply remove the device, unscrew the bolt that we have in there, put a couple of stitches here or a couple of staples, and the wound is closed. So again, the NeuroBlate system is the one that we're using here. There's also a system at St. Luke's Hospital here in Kansas City. Apart from these 2 hospitals, you pretty much have to go to St. Louis. St. Louis was one of the first places in the country doing this a couple of years ago, but there are more hospitals getting this system all the time. Here are a couple of people that we have done the laser on. This is one person here with the laser, and you see how deep it was, the trajectory that we took to it. Right there, the probe going right through it. This was a tumor that we could have conceivably just done a standard surgery because it's not a deep tumor, it's right there on the surface of the brain. But because this gentleman was infirm, going to sleep for several hours, losing blood, etc., was not in his best interest, and so we simply placed a very small twist drill hole, dropped the probe in, fired the laser, and was able to go home the next day. This is one of the most recent articles showing the role of laser in enhancing progression-free survival in high-grade gliomas. Gliomas are primary tumors of the brain. They grow in the brain, they don't go anywhere else. They come back in the brain sometimes if they're in the higher grade form. And many of these occur in very deep and surgically inaccessible areas. Brainstem, the thalamus, very deep. Places that, we have to go through this much normal brain to get there. And in doing so, many times you hurt people. You end up with a bigger problem, a bigger neurologic deficit than before we started. So this was in treating difficult to access high-grade gliomas, which are deep gliomas, and they found that the survival rate was better in those patients who had the coverage of the laser better than not. So these were, you can see 13 patients where they had what they called favorable laser thermoablation coverage and unfavorable, and showing that killing more tumor resulted in longer survival, et cetera, in these patients. And these were these were people that would not have undergone open surgery. It wasn't offered to them, even as a possibility. Before this, what you got was chemotherapy and radiation, no surgery. And now you can have surgery via the laser and chemo and radiation. This was the first trial, the first publication using it in recurrent glioblastomas. Glioblastoma is a very difficult tumor to cure. People with this survive anywhere from 6 months to a year and a half, 2 years. It's very difficult to get beyond that. We struggle, and the NeuroBlate has been used in those patients who have a recurrence of their glioblastoma or their grade 4 tumor in certain cases. So what can we do for glioblastoma? After radiation, after chemo, we can reoperate. We can reoperate if it's focally recurrent. If it recurs in a very large area, that's difficult to do. So rather than reoperating open, could we use the NeuroBlate? And so that's one of the applications for it. This is a single institution series, the first such and the largest such, 17 patients at Washington University, published in 2013. The other indications besides the tumors that I mentioned are these: radiation necrosis. Okay, so many times it's difficult in tumors that have been operated and radiated and treated with chemotherapy. There is edema around them, swelling. Many of you know that. And we don't know, is that tumor-related edema? Is it radiation necrosis? Has the edema and the growth in the enhancement really not tumor at all, but radiation? So many times we don't know. Well, we have found that even if it is radiation necrosis and not tumor, that the laser is effective in that. It does something to this necrotic tissue to diminish the amount of edema and improve symptoms, and we've had the opportunity to use it in several cases for that. We use it in patients with significant comorbidities, people who are unable to be put to sleep for long periods of time because their lungs are so bad, etc. We've used it, and we're actually one of 6 total, but 5 other centers in the United States participating in a clinical trial called the LASER multi-center study, which you see here, which are people who have had radiation, radiosurgery for their metastatic lesions where it starts to grow again. So in other words, tumor somewhere in the body spreads to the brain, it gets operated or at least radiosurgery to that lesion, and then begins to grow after radiosurgery. We never used to see growth after radiosurgery because patients died of their primary disease. But doctors have gotten so good now, oncologists, at treating cancers in other parts of the body, that we're finding that, we'll radiate the brain lesion, but then a year or 2 or 3 later, it grows back. So the radiation hasn't actually killed it or eradicated it like we used to think it did. And so now we're using the laser as a way to kill that remaining tissue after failed radiosurgery. There was a published report, or there will be a published report, I believe this week, in using the laser for psychosurgery. So, saying, oh, what is psychosurgery? Well, you think back in the days of lobotomies, when surgeons would go into the brain and cut certain fibers in the front part of their brain to make nursing home patients or psychiatric patients more docile. One Flew Over the Cuckoo's Nest. Anybody who's seen that movie will know that. And this was a huge treatment back in the 40s, but went out of vogue, not only because it really hurt a lot of people as far as their, it made them much more docile and able to be managed in a psychiatric facility, but because of the advent of neuroleptic antipsychotic medication, when we finally had pharmaceutical agents that we could give people to control their psychoses, nobody was doing psychosurgery anymore. Well, there still is an indication in certain conditions, one of them being extreme, horrible chronic pain. There's a procedure called cingulotomy, where you go in and you lesion 2 parts of the brain, one on each side, that are deep. When I was a resident, we used to do this with a radiofrequency probe. We would put it in, heat it up for X amount of minutes, and hope that we got the the right lesion size. Now we know in MRI we can do it with a laser and get a perfect lesion. We know how big we're going to make it, etc. So it's much safer with the laser. And one surgeon is just reporting their series, I think, this month of 3 cases. And then other tumors. Again, I have a suspicion that 5 or 10 years from now, this is going to be, we're going to have our indications and applications tightened up quite a bit. What this is really good for, what this is effective on, and what this is ineffective on. And right now we're kind of searching. And so meningiomas, there are surgeons that are using this for benign meningiomas, a special type of tumor in the brain that does not grow very fast, but rather than going back in after it when it regrows back, perhaps use the laser. Cavernous angioma is a type of vascular malformation that is relatively benign, usually does not result in catastrophic bleeding. Could we use a laser to ablate a cavernous angioma, shrink it down? So these are just some of the other indications. Another one would be pain procedures. There are not only the procedure I mentioned, the cingulotomy procedure, but you can make lesions in other parts of the brain for pain, to diminish pain in one or another part of the body. And the most obvious other indication that I have not included here, but is currently being used for this, is epilepsy. So surgical treatment of epilepsy is something that is very helpful. We treat this at KU all the time, where we go in and remove a certain part of the brain that is causing irritation and causing people to seize, people on 3, 4, 5 different anticonvulsant medications. So we go in and take out that irritative part of the brain by doing open surgery, and they have no seizures. So it's a really, really wonderful procedure for quality of life. Well, now we can stick the laser in there, and provided that the irritative focus is small enough, we can ablate it. We can burn it out literally with the laser without having to open the whole head. So that pretty much sums it up. That's laser interstitial thermal therapy, and I'm willing to entertain any questions. Yes, ma'am.
We came in late, so I figure we probably missed about 5 minutes of your
Not much, yeah.
But what determines who's going to get this instead of surgery? Is it like the first option that you think about for everybody that comes in now?
So that's a very good question. We think about it now for everybody. What we don't, and we will offer it to people specifically if the tumor is small enough. So the laser is limited. One of my slides that I showed that one of the probes goes out about 1.5 centimeters on either side, and another probe goes 2 centimeters. So at maximum, we're thinking 3, maybe 4 centimeters in 1 or 2 dimensions would probably be a maximum size. Well, that's what we used to think. Now the kind of people on the edge are pushing it and saying, okay, put the laser in twice. One trajectory here, one here. You can get big lesions then. So we are kind of expanding our indications a little bit, but size is one thing. Location is another. If it's very superficial, right under the skull, and it would be just as simple to take a 2-hour procedure, take the skull off. If you're very healthy, it's not a serious risk. If you are unhealthy or have serious lung problems, risks about going to sleep, things like that, so we would consider the laser. A very deep location, we would consider the laser. So a lot of things go into the choice of what we think would benefit from this and not. And as we get more experience with it, we're including more people in that. So you don't actually remove the tumor. That's another thing that I really didn't bring up, but it's sort of intuitive. The laser kills it, but then it stays there. So that's good and bad. If you've got a big mass in there causing pressure and pushing the brain aside, it's not going to do a lot of good just to kill all that tissue, because it's going to be weeks before the body gets rid of all that mass, that dead tissue that's left in there. So people who are suffering from mass effect, pressure, we got to get that pressure out, and the only way to do that is to take the tissue out. Now, surgeons are, again, pushing the envelope and saying, okay, let's ablate the tumor, and then let's go in there the next day and stick another little tiny thing in there that chews up the tumor and suck it out, or wait a few days and do that. So at some point we may be doing something like that for the very, very large tumors. Leaving the tumor there, you think, is a bad idea. Well, why can't you just get it out? But there are indications that perhaps it may not be so bad, leaving all of this dead tissue there, because then that acts as a nidus for the body to recognize, oh, let's go after that. We've heated up the tissue around it, we've killed the blood-brain barrier, so now maybe inflammatory cells can get into the tumor where they couldn't before because of this barrier that we're born with that doesn't allow our immune cells in or chemotherapy in. In St. Louis, they're doing a trial of a very special type of chemotherapy that really never gets into brain tissue. I mean, it's very little. It's used for other tumors, solid organ tumors, lung tumors, liver tumors, things like that, but doesn't get into the brain. Well, they're using it in the brain in people who've had the laser treatment. So they give the laser and then boom, follow it with this chemotherapy because the brain, the barrier, the quote blood-brain barrier has been opened and the chemo they think is going to get in and kill the tumors.
How long have you been doing that here at KU?
So we've only had this for about 6 months. I think we have done now probably 15, 16, Tim, I don't know how many have we done, probably something 15 cases. Like I said, I just heard today there have been over 300 cases now done in the country. But really, really hasn't taken off till about the last 6 months, maybe 7 months. Yes.
There's less risk since it's so little more minimally invasive of stroke and stuff like that, is that right?
Right.
And have you found, I know it's been a short period, what about the lesions or scar tissue? You never need that?
So it does create some scar tissue in there, and then that, we're looking at the scans 3 or 4 months later, and you say, gosh, is that tumor that's left, or is it scar tissue? And we're kind of left with those issues. Those, I would be, denying that this is a perfect treatment. We, end up, we're sometimes unable to cover the entire tumor. Glioblastoma, astrocytoma, is not a focal lesion. We know that. I mean, 50, 60 years ago, when surgeons recognized it, always came back, usually in the place where it was originally. They finally went to cutting half the brain out there. So, I'm going to slice it off. You're going to be paralyzed, but at least we're going to cure you of the tumor. And then 2 years later, come back on the other side. So we know that glioblastoma is not a focal disease. So you say, well, why are you treating a focal disease or a non-focal disease with something focal like this? So yes, that's a legitimate question. We're not going to kill or cure glioblastoma, but you can kill 90% of it, which is what we're doing with surgery in many of these cases, and then we use our other therapies to finish it off, as it were. So this is like, we're considering this a substitute for maximally invasive surgery.
You used also maybe palliative.
Yes. Mm-hmm. Somebody's having a lot of pain, etc., that's had a recurrence, a third or a fourth or a fifth recurrence, and they don't want another big surgery. Could you stick this in and kill 90% of what has grown back, to help that? So yes.
But with the glioblastoma, as the tumor comes back, then you can go in with this laser thing?
If it's focal, yeah, we can go in if it's a smallish recurrence and burn that part out. You can think of it like as a surgical substitute. But if it's a big recurrence, if it's recurred at all around a cavity, let's say you have a cavity like this and it recurs all around here, that wouldn't be a good case for this. But if if it's been gone for a year and then it pops up over here in a relatively focal place, yeah, rather than have an open surgery, we could put that in there and help it.
How long
Yes.
does it take for the laser to warm up?
It's very quick. We test it before we place it in the patient. We put it in the patient. We get a series of MR scans that usually takes about 5 minutes, and then the laser takes literally 30 seconds to cool down, and then we wait till it equilibrates at 10, 12 degrees Celsius, and then we hit fire, and within instantaneously, really, it gets up to 43, 44, and much higher. We can, one of these slides, you can actually take temperature points in the brain, something like this, where we're, I'll take my mouse and click right here. Within 30 seconds of the laser firing, I'll see that this point here may be 43 degrees. And then another 30 seconds, it may be 60 degrees Celsius. So it's really really heating up really quickly. Yes?
Can you use this below the corticoid from the optic nerve and sinus?
Yeah, that's a good question. I am not sure if it has been used in the pituitary gland or the sinuses yet. I don't know why not, but the MR sequences that we use are pretty specific for the brain. They're gradient echo sequences, and I'm not sure that there are so many confounding factors like air in the nose and things like that. You're dependent upon a slab of tissue that is relatively homogeneous, and you pick temperature readings around there that lets the software know what the actual temperature is inside that slab. So I would say for the moment, no. But
Bone might confuse it also.
bone confuses it. Bone, air does. The actual probe does. We can't get temperatures right around the probe where that is, but the ventricles do. I mentioned before, blood, large veins next to the thing. I've had this in tumors before where we're heating, and it's growing out one side, and we just cannot push the temperature over to this side of the tumor because of a big vein right there, or a ventricle with fluid in it. Yes?
What about refining edema versus tumor? Like when I had mine, they didn't know if it was edema or tumor.
Yeah. So it's not, the laser buzzes or heats what we tell it to heat. So if we don't know whether it's tumor or it'll heat edema if we tell it to heat it. I mean, we just turn it on and off by watching the temperature map expand. So it doesn't really help us determine edema from tumor, swelling from residual tumor. We have not used this yet, at least I haven't, in benign or slow-growing tumors. I don't know why it couldn't be used, and I think, again, with people pushing the envelope, people are starting to use it for low-grade tumors. But usually those are the cases where we're concerning about a tumor versus edema, the lower-grade lesions. For most of this, we use contrast-enhancing tumors. We're doing it on tumors that light up on an MRI scan. Now, we have seen, if there is a lot of edema around a tumor, once we ablate the tumor, we've seen several weeks later the edema go away or go down. So that would be one way to tell tumor versus edema. If it goes away, then it was swelling.
What time frame for going away?
That's another good question. Most of the literature says not to even get an MRI before a couple of months. You get an MRI in a month, it won't look a whole lot different. Maybe a little bit smaller. So 2 months it should start to contract. 3 months, 4 months should start going away. If it doesn't, or if it starts getting bigger, then we worry that we didn't get it all. But it's not going to go away right away. Most of the studies that I showed you tonight, they have 6 month, 1 year scans showing slowly going down. So the fact that it hasn't gone away in 2, even 3 months is not worrisome. And as a surgeon, that's a little kind of intimidating to me because I like to see it gone. When I do surgery open, the next day I get a scan, there's nothing there, or just a little bit of stuff there. When I do this, it's like, well, it's not gone. Let's hope it starts shrinking in a few months.
So you let the oncologist watch those for you too?
Yes, yeah. Yes.
What factors do you consider both in a more invasive surgery than this operation when you're choosing surgery? What are the things are you looking for the quickest way to the tumor, like the least amount of tissue?
Usually the way that gives us so because this thing can't bend, it's just a straight rod, we want to get it so that it will, contour. This is a nice little football-shaped tumor here, but most tumors don't look like that. They're, might be elongated at the bottom or elongated at the top. And so what we do is we get on a computer and we draw this little thing out in 3D, and then rotate it around and try various trajectories and try and figure out, which one is going to give us the best coverage. And then how we're going to do it with the side firing laser or the one that generates a big sphere. And so it's not as precise as like me with my eyes and a microscope going in and going around it, because let's say you have a tumor that is not football shaped but is small here but really big here. We're going to try and pass the probe so that we can get most of it, but to get all of it you might end up destroying some normal brain adjacent to this part down here that's very small. So the probe is small enough that we really don't do any damage, even going through pretty eloquent parts of the brain. Like we could pass it right through the speech area here, and because it's blunt at the end, it kind of pushes the neurons out of the way, and so you wouldn't expect to have any problems. So the place that we pass it now, we don't want to pass it, directly on the side here where there's a lot of big blood vessels, and we with our computer guidance system, before we put it in or even drill the hole, we can see what big blood vessels are nearby that we can avoid. We want to avoid the optic nerves, the carotid arteries, the middle cerebral arteries, things like that. So we'll try and avoid those things, but in general, we pick the trajectory to give us the best coverage. And if we can't do it with one pass, then that's when it comes, to do another pass.
So
And-
the survival rates of patients from now on, now that something like this is being used, should go way up?
I wouldn't say way up. I think this is a less invasive, less downtime, more easily tolerated alternative to open surgery. So for that reason, I would say deep lesions, yes. Deep things that we would not have done open surgery on, yes. Survival should go up because we're killing it with this first before we give the other therapy. And then, you could say maybe survival with glioblastoma patients or really malignant tumor patients whose tumor comes back and is able to be ablated, that the survival would be extended in that as well. You might have people that are getting really severely sick and disabled from their tumor who would not tolerate an open surgery, but who you could do this on. So yes, it could extend that survival. Mm-hmm. Sure. So many people with epilepsy are not amenable to surgical cure, but many people are. And very, very many people who have epilepsy are, for whatever reason, their doctor doesn't know about it, or their doctor has them on 2 or 3 different medications and they're still having seizures. But we evaluate a number of patients every week with what we hope is surgically curable or preventable epilepsy. And you know what epilepsy is? People who have seizures, oftentimes grand mal seizures, sometimes less than grand mal seizures, more than one. And they can't drive, many can't hold a job, they have memory problems because they're constantly, parts of their brain are seizing. And so we find that very, very many people come late to us. Today we had an epilepsy conference. We have it every week, and we evaluate a number of people. I had, I think, 2 or 3 people today presented. One of them was 24, had been seizing since she was 9 years old. Another was 60, been seizing since they were 18. I mean, living 30, 40 years on seizures with 3, 4, 5 different medicines making you feel like a zombie all day. Well, if in some of these patients, not all, but in a great many of them, we can localize the epilepsy to a certain part of the brain. And we do that either by EEGs that they put on the surface of the brain, or more likely by us surgeons putting in little electrodes deep into the brain in the area that the epileptologist suspects the seizures may be coming from. And if we can localize that to a small area, 2-3 centimeter large area or smaller, then we can take that out if it's not in a critical part of the brain, like place that controls your speech or your right arm or something like that. And many times they're not. Now, sometimes they are, then we can't do anything, or at least we can't remove it. You could put a stimulator in there, and there are other things that can be done. But if it can be removed and can be removed safely, then we either do that open or we do it with this now. You can put this in there, and you've localized the epilepsy to this, 2 centimeter cube of brain that's about 2 centimeters in right here. We put a probe in, kill it, or ablate it, and then their epilepsy is cured. So we have, if you can see on MRI the scarred area, and if the electrodes show you that that's where the seizures are coming from, you have a 70, maybe 80% chance of being cured of epilepsy with this kind of an operation. So that's a big deal for people who are on all these medicines. Okay, thank you.
I'd like to thank you for presenting tonight at Camarata. Thank you all for coming and welcome you back next month, first Tuesday.
Thank you very much.
There's a lot of cookies out there, so please take some on your way out. Better to go home with you than me.
we have things like this disease, things like, you know.
But it was a great experience to see some.
Well, that's one nice thing about me. We were always looking at something from the radiology. Tim, I'm Casey. Nice to meet you. All right. How are you doing?
Pretty good. I mean, Randy's, what is it? Your mom? I'm mom, yeah.
So that's, this is our,
What is it? Yeah, that's our Kathleen.
I know, I'm a Catholic too.
Oh,
Yes.
Kathleen.
Yes.
Two fighters.
Yes, oh, yes.
Strong Kathleens.
Yeah, I found something really interesting. My girls do so well growing up with a bunch of brothers. Because I'm part of the life family. Yeah.
And you grew up with brothers?
I have 4 young brothers.
Oh my
I said
God.
I like to raise them.
Kathleen is the oldest.
Well, my brother commented that, being in fear is not necessarily being raised.
Yeah. Oh, so that means you were pretty tense.
Oh, I was.
You were a real mom.
I was just running. Well, there's some of us, so, you know, you always have to be a mom.
Yes, and you know what, I was pretty strong will, so if I handle it, God will you right after this goes.
Me too.
Oh, the boys were good, but just big boys, right?
Absolutely. Oh, there's some different boys too.
I
Just
know.
so you know. Nice seeing you. You guys have a good night.
You as well. Take care.
You too.
That seems that way. I'm fine, take care. Or you see the magazine.